OBGYN, she did not know about some of these things, and she felt like she did a disservice to her patients by not talking about menopause. And now she's one of the most vocal people in this space. And so she has her Instagram feed, and she writes a blog post and so on. And in that, she had some statistics which I wanted to just share, and you can see it on the screen. I just took sort of a word cloud of all the symptoms that are associated with perimenopause and menopause. The bigger they are, the more frequently they have been cited as issues. And the table below is what I've taken from her site about the top symptoms as reported by her large following of women. And to the points you just made, right? Fatigue is considered one of the biggest ones. And people wonder, right? Women wonder, I don't know why, now do they just feel tired? Well, that may be a sign that you're in perimenopause.
It's very common.
Right? Very common. That seems to be the most commonly cited, at least. Sleep disturbances, you spoke about, weight gain. I do exercise, I do all the things I've been doing my entire life, but now suddenly I'm putting on weight. Why? Well, there is an explanation here. Brain fog, joint and muscle pain, and so on and so forth. But I just wanted to flash this slide up because I think it gives, or it hopefully gives the feel, the sort of consolation that, if you're going through it, it could very well be a perimenopause or menopause issue rather than I don't know what's going on. Right?
True.
And so one of the things that a lot of women talk about is, well, I have all these things, but when I go talk to my doctor, they will tell me, well, deal with it, or they will address a different issue rather than the one that may be the root cause of all of this. And I'll tell you one anecdote which I heard recently. I was talking about the fact that we were going to do this session, and this friend of mine told me that she had a frozen shoulder. And she went and spoke to her OBGYN about the frozen shoulder. And her OBGYN said, well, you need to go talk to orthopedic surgeon because it seems like that's the issue. And the orthopedic surgeon was all ready to do surgery. And then she happened to meet a friend who's also a doctor, and he said, hold on, why are you doing all of this? This may just be an issue with your estrogen drop during perimenopause. Before you please go and do a surgery, please go see the right doctor. She goes to this other doctor. The other doctor says, yeah, this is absolutely perimenopause. Let's address it. In her case, it was through BHRT, hormone replacement therapy. And within a few months, that thing went away. But the system was ready to operate on her.
Yeah. But Nikhil, it happens to it. I mean, let me confess that I was one of those gynecologists some years back, and I would definitely ignore these symptoms and try to find different solutions to, just fatigue or mood swings. And these patients still come to us, regularly come to us, and we don't handle it the right way. Other than maybe the genitourinary symptoms, nothing else is handled properly. Let me be honest about it.
Yeah. No, I'm so glad you're talking so openly, Mugdha, because we are all trained to say if the doctor says so, it must be true, right? But this is one area where, because of all the things we spoke about earlier, there's a lot of lack of knowledge, awareness because of various issues. But we can't just take things at face value.
Yeah, I think that trial in WHI trial in 2002, that possibly is the culprit for us gynecologists to sort of not suggest HRT, because for us at that stage, HRT was a no-no. Just not give HRT to anyone, or you call it MHT, whatever.
Yes. Yeah. And I think that's sort of really something that is, even today, that 2002 study is resonating, because if you're not taught in school, in fact, if you're taught, please do not do that. you have to really keep up.
Yeah.
Okay, maybe now
Yes.
I need to change my mind,
True.
right? And I think you also mentioned one critical point, which is UTIs are amongst the most common symptoms of perimenopause and menopause, right?
Yes. Yes. So what happens is the vagina has basically is the vaginal epithelium is estrogen dependent. Vagina, urethra, even the urinary bladder to some extent, the epithelium is dependent on the estrogen. So when the estrogen levels fall, this epithelium becomes thin. It secretes glycogen. The glycogen secretion reduces, so it becomes dry. The pH changes. So because of this change in pH, you're more prone to getting vaginal infections, more prone to getting urinary infections. So it's pretty common actually, vaginitis and urinary infections.
So, this is actually very fascinating to hear the sort of the biology behind it, right? That's causing it.
Correct.
And I think the root cause of it is, the
Estrogen.
hormones, right? Estrogen, progesterone, and even testosterone, right?
Yeah.
Um, can you, Mukta, just for the common man like us, explain what's happening? Like you said, before perimenopause, a woman's risk of heart disease is lower than men.
Correct.
After menopause, it's higher than men, which means estrogen and all these hormones play a critical role. But what's actually happening in the body?
So just let me explain. So each lady is born with a fixed number of eggs in her ovaries. So that number depletes over the next few years. Above the age of 45, the depletion is faster. Now, this ovary secretes two main hormones, that's the estrogen and progesterone, and another one which is testosterone. Now, estrogen actually is required for your menstrual cycles to develop the endometrium and for a pregnancy also. And progesterone is a hormone which supports pregnancy. But other than that, they have a lot of other functions like estrogen is required for the skin elasticity, it's required for bone health, cardiovascular health. It improves the insulin sensitivity. So if estrogen falls, insulin resistance develops. Body fat distribution. So the body fat distribution changes when the estrogen levels fall. The metabolism, cognition. Estrogen also stabilizes serotonin. So mood disorders, mood swings, irritability also increases when the estrogen falls. So what happens at menopause is that the estrogen levels and the progesterone, they start falling. So when they are working together in synchrony, the estrogen, progesterone, testosterone, everything is fine. But slowly as they start declining, then you start getting all these symptoms. And at menopause, estrogen levels are very low, estrogen, progesterone, and testosterone. Now, testosterone is important to maintain the muscles. Also, testosterone helps us to in our metabolism. So, but what we say that, I eat that much, I exercise that much, but I don't lose weight. That's because of fall in the testosterone. Also, the libido goes down. That is also because of fall in testosterone.
Right, right. And the one of the things you spoke about was the insulin sensitivity, right? Insulin resistance goes up because estrogen
Yeah,
plays a role there. And that shows up in a lot of the things you spoke about, right? Body fat, heart disease,
correct,
your HbA1c is beginning to go up, your cholesterol is beginning to go up, but you have not changed anything else.
correct. So that's the reason it happens. Yeah.
Got it. Got it. And so what that says is uh, the whole perimenopause and menopause period is depleting three critical hormones that have kept that plays such a critical role, and
True.
now they are gone or pretty much
Yeah.
gone. And so, is that where the concept of HRT came in? That well, if the body is lost it, we need to replenish it. Is that how the HRT concept came about in the first place?
Yes. So initially, that's what was thought of, that because the hormone levels are falling, and so that's why they started giving HRT. The HRT that was given initially was basically for maintaining the bone health and improving the cardiovascular health. That was the main reason that they considered to give HRT. before 2000. And the medicines that were used at that time were mainly oral medication, that was conjugated equine estrogen and the progesterone. Now, those were the problem. I mean, they were the ones which caused the issues in that trial, where they increased the risk of breast cancer, where there was increased, they found that there's an increased risk of breast cancer, cardiovascular accidents. That is the reason that these hormones, this estrogen and progesterone, that what was used is for this trial and used in the wrong age group, caused the problem. So HRT used for the right people at the right time will definitely help.
And I just want to make an important point that you sort of just stated, just for everybody's sake on the call. Uh, Before 2000, the HRT that was used was mostly synthetic, right?
Correct.
Now, the reason it's called MHT or BHRT is because it's bioidentical hormone replacement therapy. So it now is much more similar to the way your body would produce it rather than this artificial
Correct.
way of doing it. And I think that is a pretty critical piece in addition to the other point you made, which is the age group when it should be provided.
Yeah, so the two things that were there is that the estrogen, so basically what was done is estrogen and progesterone were replaced. Now the estrogen that was used was the synthetic estrogen. Now what we get are the estrogen which are similar to our body estrogen. That's chemically and molecular, they're similar. And even the progestrogens that we get are the natural micronized progestrogens, which are much better and have lesser side effects. And the routes have also changed. So instead of oral medication, there are other routes of medicating.
So what are they? What are these other ways of
Yeah.
medication?
So let me talk of HRT first. What is it?
Yeah.
It's basically, it was called HRT, that's hormone replacement therapy. Now it's called menopausal hormone therapy, MHT. Now that's basically replacing the two hormones, estrogen and progesterone. It can be used for various reasons, but most commonly it is used for vasomotor symptoms and genitourinary symptoms. For prevention of cardiovascular risk, for prevention of bone density loss, it's not recommended for primary prevention. It can be used in certain cases, but definitely should be used for vasomotor symptoms and with genitourinary symptoms, fatigue. So all these symptoms, we can use it. The thing is that you start with the lowest dose and use it for the shortest duration. The patients whom we give it to, they have to be seen by the gynecologist, they have to be evaluated properly, and then only we can start the HRT. If a lady has undergone a hysterectomy, her uterus has been removed, then we can give only estrogen. We don't need to give progesterone. But if she has an intact uterus, we have to give estrogen and progesterone, because if the estrogen acts on the uterus continuously, there's a risk of endometrial hyperplasia and later endometrial cancer. That's the uterine lining cancer. So every cycle, we have to give estrogen plus progesterone for a lady who has a uterus. So the routes that we use are oral, estrogen and progesterone combination, transdermal, which can be in a form of a patch, in the form of a gel, a spray, and vaginal. Vaginal rings, vaginal gels. So all these are available.
Got it. Got it. And one thing I'd love for people who are listening in, if you are going through it and want to share any experiences that you have, please definitely feel free to do so. Because, one interesting thing is in the US, because the healthcare system was not serving this market well, of this market of women who needed it, companies have come up that only do BHRT. And they have their own team of nurses and doctors, and they play the role that the healthcare system should have played. And some of these companies are the fastest growing companies in the United States in the healthcare space. There's this one company called Midi Health, and there are many more like them, Alloy Health and others. But Midi Health went from, in 5 years, Mugdha, from a concept of a woman who suffered from this whole thing herself, to saying, why are we going through it? She was not a doctor, but she said, why do women have to go through it? So she got a team of nurses and doctors and started offering this. And I think last I heard, in 5 years, they went from zero to $200 million in revenue. And that's one small company. And so, in any case, this is a big thing. And I know there are women on this call today who are going through it, who have dramatically benefited from it. And I would love for them to share, in the chat window, what their experiences have been. But moving to the next question. So one is HRT, and that is a whole big topic in itself. Lifestyle. What are some of the changes one can make in one's lifestyle that can help with dealing with some of the side effects?
So I think the lifestyle changes should start early. So we can call the late 30s, early 40s as the critical window. If you want you to to have a healthy life after the age of 50, 55, you have to start early. So the lifestyle changes will be dietary changes, where you have to have, you can have more of phytoestrogens in your diet. You can have maybe flax seeds, more of calcium in the diet. Reduce the amount of carbohydrates, especially saturated carbohydrates, more proteins in the diet. Regular exercises. Exercising should just not be cardio, but also some amount of strength training, resistance training, because that will help to improve the muscle and the bone. Then, so exercise, diet, some amount of, if you have a lot of sleep disturbances, then a person you have to follow certain protocols that, reduce your alcohol, reduce smoking if you're smoking. If you're obese, you have to lose weight. Follow a strict timing of sleeping. Before sleeping, you should be off your devices, off your laptops, and some amount of cognitive behavioral therapy can also help.
Got it. And a lot of the things that you just said, Mugdha, we talk about as good health practices in general. They just become even more critical during these years.
True.
Right. And I want to sort of specifically pick on a couple of the points you mentioned. One of them is strength training. I think strength training everybody benefits from for a number of reasons that we have spoken about on various calls. But the interesting thing is that the FDA, the only thing that approved HRT for was to protect against bone loss.
Yeah.
And strength training is another great way. If you don't want to do HRT and you want to protect against bone loss, strength training is absolutely a critical tool you have in your toolbox to deal with it.
True, absolutely.
And then sleep. I think sleep is one of those things that it almost doesn't matter what age and what gender. Everybody seems to struggle with sleep. And I think in the coming weeks, one of the experts we are bringing on is a sleep expert, because I've seen in all the blog posts I've ever written by sort of theme, the posts that get the most readership are the ones around sleep, because that seems to be, the world seems to be heavily sleep deprived.
No, that's true, but menopause really affects the sleep. And a lot of patients come with insomnia, sleep disturbances. They wake up early, they can't sleep well, and that affects everything then.
Yeah. I want to ask you a couple more questions and then open it up because there's such a long list of questions that we've got.
Okay.
So, but the couple of questions I still want to ask you. One is there any testing? Because hormones are going up and down during perimenopause, right? Is there even such a thing as, let's test, because doesn't it depend on the day you test what's happening? Is that really giving you a clear picture, or are there certain things you can absolutely test for?
So there are tests actually, Nikhil, but we really don't recommend them. So there are certain hormone tests that you can do. I'll just name a few. One is called AMH. That's called the anti-Mullerian hormone. This hormone is a test of your ovarian reserve. So we do it for a lot of our fertility patients. In menopause, the problem is we don't know. So, like, it's like taking the hormone levels are fluctuating all the time, but we are just taking a snapshot when we do the test. So we don't know where we are. So if I do a AMH, normally a AMH should be more than 1. But if a AMH is 0.1, it doesn't tell me anything about her menopause, because she can get a menopause 1 year down the line. It can happen 4 years down the line. Another test is called FSH. That's the follicular stimulating hormone. This test should be done on the second or third day of cycle. Again, when the FSH is high, more than 25 to 30, we can say that you're in the perimenopausal range. But I cannot predict that your menopause will be in the next 6 months or the next 2 years. So that is the problem with these tests. And estrogen, another level. But estrogen levels are again fluctuating. They fluctuate during the day, they fluctuate throughout the cycle. So you can't keep on testing for them. So really, there are no tests needed to be done. The only place where there is a role for testing is when the lady has a poor ovarian reserve and is trying for fertility treatment. She's around her late 30s, early 40s. That's when we would test. Or someone who's come to me with maybe a history of 3 months of amenorrhea, no periods. And then I would like to know why it has happened, whether it's because of some thyroid disorder, whether it's because of menopause. Then I would like to test. But then those tests will include a history or detailed history taking, a transvaginal ultrasound where we actually check the volume of the ovaries, the antral follicle count, that's the eggs in the ovary, that's the follicles in the ovary, and the AMH, and maybe a thyroid profile. That's how we will be able to differentiate and find out the cause of her amenorrhea. But really, we wouldn't suggest testing for all women.
Right. No, that makes complete sense. And would you ask women to test for, like, do a DEXA scan for bone density?
Yeah, so I was coming to that. Yeah, so if a woman comes to me, like she's 40, 45, and she would like to go ahead with some testing, I would recommend certain blood tests, which would be a normal CBC, liver function, kidney function test, thyroid, definitely her lipids. I would ask her to do, if she's above the age of 45, mammography, an ultrasound, a pap smear, and a DEXA scan or a bone density test. All these should be evaluated. Based on this, we can also assess her symptoms and then decide whether she can be started on MHT, whether she requires it, and for what reason should we give it.
Got it. I want to go to a question along these lines. Is there any truth to the statement that your menopause age/journey will roughly follow that of your mom's?
Yeah, there is actually. It is. So the menopause and even puberty is usually is genetic. So if we know that a lady's mother or her sister had an early menopause, we expect that she also might have an early menopause. There's also an issue. We do see that in patients who are taking fertility treatment also. So just to add to that, actually, if we have women in their early 30s who are still maybe not thinking of a pregnancy, we tell them to do the AMH test, because yes, we do see early menopause, we do see premature menopause, even in the age of 30, age of 35. So yes, a family history does matter.
Got it. So now I'm just going to go through the questions, Mugdha. I'm going to just keep firing them. And
Sure.
first one, is it a must to take calcium supplements during the menopause period?
Not a must, but it would be better if you take supplements around 800 to 1200 grams per day of calcium, along with vitamin D3. You should better to take it. D3 around 1000 international units per day, or you can take it like a weekly dose of 60,000 international units for 8 weeks, and then you can take it once a month. But I would prefer to test.
Got it. And keep every year or so, do your DEXA scans to make sure all of that is getting.
Maybe every 2 years. Also, your
2 years.
B12 and vitamin D levels, because I think Indians are vitamin B12 and D deficient.
Yeah. Most Indians are, right?
100% almost. I mean, vitamin D sometimes we don't even test.
Right, right. You can almost assume.
Yeah, true.
Um, then I think we've covered some of these, but I'll just go. Supplements or lifestyle changes that are recommended for traversing this journey gracefully, especially on a vegetarian diet.
Okay, so on a vegetarian diet, again, yes, supplements you can take calcium, vitamin D, you can take magnesium. Uh, Other than that, a healthy diet in which you take adequate proteins. Proteins anywhere between ideally would be 1.5 grams per kg of your body weight per day. But then you have to also consult your physician because sometimes you can have, especially if you have kidney disorders, then you can't take very high doses of protein. A wholesome diet, phytoestrogens are very important. So you can take phytoestrogens. Soya is a good source of phytoestrogen. That these are plant-based estrogens. So simple solution can be to your normal atta. You can add some amount of soya atta. You can add that also. That can also help you. Then you can have. You should have proteins through legumes. Have berries because they have antioxidants. Estrogen, fall in estrogen, progesterone increases inflammation. So it's good to be on an anti-inflammatory diet because that will also help you.
Yeah. Yeah. No, that's great. And we'll make all those things that Mugdha is talking about, we'll make sure that they show up in the show notes. I remember a few months back, we had actually published an example of an anti-inflammatory diet. So we can add that into the notes.
Yeah.
I think we already described when does one need to start HRT, but maybe you can just explicitly address that, Mugdha.
So we don't give HRT to every lady. I would definitely recommend HRT to a lady who's got vasomotor symptoms, who has got genitourinary symptoms. For them, the HRT will be started on, or MHT will be started with the minimal dose. I would prefer to use a transdermal application, which can be in the form of a spray or a patch. I use a spray more often, spray and gel. I counteract that by giving a progesterone for 12 days or so, or you can also use a progesterone IUD, which is placed inside the uterus. That is called LNG IUD. For prevention of bone issues or to prevent cardiovascular risk, HRT is not ideally given primarily for that. Whenever we start HRT, it should be started immediately after you attain a menopause, preferably in the first 10 years. That's the maximum benefit you get. Usually after 10 years, you will not get so much benefit with HRT. For
10 years
fatigue,
after menopause.
yes, after menopause. For fatigue, for sleep disturbances also to some extent, it will help. Muscle pain, joint pain, frozen shoulder, all these people, it will help. 100% it will help.
Yeah, I think the next set of questions were around the muscular stiffness, low strength. Could these be due to menopause or lack of nutrition?
It could be a combination of everything, but in that age, menopause will be critical.
Yeah.
And yes, you can go on HRT, but I would still say when you go on HRT, I think it's a time where you can evaluate your health. It's a very important situation, and you can evaluate your health issues. If you are obese, you have to lose your weight. If you have blood pressure, diabetes, lipid disorders, you will have to control that. And if you have these menopausal symptoms, we can put you on HRT. How long can we give MHT? It depends on your symptoms. Because unfortunately, for vasomotor symptoms or genitourinary symptoms, as soon as we stop the HRT, the symptoms can recur.
Yeah.
The vasomotor symptoms can last for up to 10 years, or even longer. So that's a bit of an unfortunate situation, but we can again restart it.
Yeah. While it's not exact, as you were saying this, Mugdha, the thought that struck me is when we talk about GLP-1 drugs, they have to go hand in hand with lifestyle changes, right?
True.
Because the moment you stop it, a lot of the weight can come back. And so if you want to get the long-term effects, you have to pair it. It's sort of similar. I almost find a parallel, right?
Yeah,
You
absolutely.
want HRT will give you that boost, but then if at some point
Yeah,
you have to get off it. And that time you are going to have to make sure that the right lifestyle factors also kick in.
correct. That's true. And
Um, yeah, go ahead.
no, and these symptoms, especially the vasomotor symptoms, are the ones are the most trouble women the most. The fatigue, vasomotor symptoms, mood disorders, the sleep disturbances, those are the most common symptoms and the most troublesome symptoms. So those we usually treat with shorter duration of MHT, maybe for a few years, but we have to monitor. When we are giving the MHT, you can't just go on that. You have to monitor with regular checkups, with ultrasounds, with maybe a breast examination, monthly self breast examination, clinical breast examination, mammographies, because these things are important.
Yeah. And I think you also brought up a point that I think is worthwhile for us to double click on, and that is there is no like perfect formula. For each woman, you have to almost do a little bit of trial and
Yeah,
error to figure out the right amount of estrogen, progesterone, testosterone. And that's why it is almost an ongoing back and forth rather than, okay, I've given it to you. Now for the next 10 years, take this dosage.
yeah, that's absolutely. So it's not, I mean, MHT is good, but it's like it's not 100% um, like without any problems. So there can be problems. It has to be given to the right person. So any person who, any lady who has irregular bleeding for which we don't know the reason, vaginal bleeding, or she has liver disorders, or she has a history of thromboembolism recent, or she has a history of coronary artery disease, or she has a history of stroke, or breast cancer, estrogen dependent cancer, then she cannot go on HRT. Some of these we can try the local sprays, the local vaginal gels, but definitely not oral.
Yeah. Yeah. Um, is it true that hormonal changes during menopause transition can cause autoimmune diseases like psoriasis?
Yes, autoimmune disease, I mean, it can flare the psoriasis. So you can see flares of psoriasis, especially in the perimenopausal age. Again, this is because of the fall in estrogen levels. Also, there are, like I said, fall in estrogen will have increase the inflammation, increase stress, increase anxiety, sleep disturbances. Again, that can flare up the psoriasis. So yes, it's there. It's a known thing.
The next question, Mugdha, was what impact does menopause or perimenopause have on the pelvic floor, and what steps can one take to maintain or build strong pelvic muscle during this period?
So pelvic floor, yes, it can. Like I said, it basically increase estrogen. Although the pelvic floor is dependent on estrogen, fall in the estrogen level will reduce the pelvic muscle, make them more lax. So you're more prone to having urinary symptoms. You are more prone to having stress urinary incontinence. That's when you will, when you laugh or you cough, you pass urine. That's called stress urinary incontinence. Or urgency, frequency, urge incontinence. This is all linked to fall in the estrogen levels. What you can do to prevent is definitely pelvic floor exercises, which are called Kegel exercises. They can help to reduce and to prevent the pelvic floor disturbances. Second thing is you might have to go on HRT for some time to help with these symptoms.
Got it. One of the common symptoms is brain fog. And uh, I think a lot of people are very frustrated with that because they just don't understand why they cannot think as clearly.
Oh, I'm going through it. So it's like,
You're forgetting words that you were 100% sure you knew,
yeah, yeah. I mean, names. That's
names.
a names. So
So
yeah.
is it just one more symptom as far as you are concerned that has to be addressed in all the same ways, or is there something different about brain fog?
So brain fog, yeah, people who are going through this issue they're more prone to have developing dementia, Alzheimer's. So in these women, we have to be careful, and monitoring CBT, ways of improving the cognition should be done. We usually don't put a lady on HRT if she has a issue with brain fog, or that's not an indication normally to put a lady on HRT. But mood disturbances, even sometimes depression, we can think of giving HRT if other things don't work.
Yeah. And, I think this is such an important point about depression, because one of my friends, I've always viewed her as probably the most positive, one of the most positive people I know. Always upbeat, everything is great. And she was sharing recently that in the last 3 years, she has been so severely depressed. And it is
No,
just
it's
very, very, it shakes you completely, because you don't understand. And
yeah.
and so these are real issues that women are going through.
So I think, for depression or mood issues, we have to first focus on the counseling, the behavioral therapy, the medications that are used for that. And then if it doesn't work, we can add HRT to it. So that's not the primary indication for HRT.
Got it. Can you explain the biology of hot flashes?
So basically, hot flashes happen because of the fluctuation in the estrogen hormone. So a sudden fall in the estrogen hormone will cause vasodilatation of the vessels under the skin, and you start getting hot flashes and sweating. So that's the reason why you get hot flashes, and it's very common. It's a very, very common symptom.
Right.
There are different medications which we can use for that, which can be MHT. There are some women whom we cannot use the hormonal treatment. We can also have some other medications like selective serotonin uptake inhibitors, or some newer medications that have come up, which we can use for vasomotor symptoms. There's something known as Tibolon that also can be tried for vasomotor symptoms.
What are your thoughts on prescribing very low dosage of SSRIs for perimenopause or premenopause induced anxiety for just for 6 days before the periods?
Oh, wow.
It's super specific.
I think this has been prescribed to someone. I frankly wouldn't prescribe SSRIs. I don't have much of an experience in giving them, and I wouldn't prescribe them. But yes, I would, maybe a physician, if they are giving it, then yes, we could try it. But for vasomotor symptoms, the best medication is MHT. If it's not contraindicated, that's the best.
Yeah. And we are doing a menopause community focused only on menopause with a healthcare system in the US. And so they have their patient base, and they are getting the patients to join that community. And over there, the chief medical officer of that healthcare system is the one who's going to be the doctor running that community. And she said that she also has the same philosophy as you. She does not. And she's a functional medicine doctor. She said she does not give SSRIs.
Yeah, it's a very, I think a lot of people do prescribe it, but it's not what I use. So I really wouldn't be able to tell you that. But SSRIs can be given, yes.
Yeah. So this is, again, as always, not meant to be medical advice, but at least you have a couple more viewpoints that can be used, Mansi. The next question is PCPs here, and I think here, I'm not sure whether here is US or India, but here certainly are not very familiar, willing to recommend HRT. First line of prescription was antidepressants for hot flashes instead of any discussion on HRT.
I was one of those doctors, I would say. And yes, in India, HRTs are not really, frankly speaking, they're not prescribed so easily. It's very unfortunate, but you'll have to find the right doctor who will prescribe it for you if you need it.
Yeah.
So,
yeah. And I know one such Dr. Mugdha.
Yeah.
So,
Yeah,
I
but
mean,
I think this forum has changed my thought process also, significantly changed.
no, that like is so amazing to hear. The next question, Mugdha, is while and this is a experience being shared by
Okay.
Smita. She said, while HRT helped me, I noticed some polyps and cysts showed up all benign, but wondered if the transdermal patch of estrogen and progesterone pills caused this. My gynac said no, but I wonder, I've never had them before starting HRT. I started HRT to prevent bone loss and osteoporosis.
So if you use transdermal estrogen, the chances of endometrial polyps or cyst in the ovaries are very, very less, almost negligible. I hope you were evaluated before you were put on that, because it may have been pre-existing. But if you do have endometrial polyps, then it needs to be evaluated before you continue the HRT, which will be in the form of a hysteroscopy and a biopsy of the polyp.
Great. Saili asked, would love to understand better why Dr. Mugdha mentioned cognitive behavioral therapy can help.
I'm not an expert in that, but yes, but to a large extent, what we know is that the cognitive behavioral therapy, especially for mood disorders, for irritability, for sleep disturbances, it does help. So I think a counselor or a psychologist will be able to answer this question better, but it does help. And before going on any medication, on any treatment, you could try this.
Got it. Out of all the available HRT delivery methods, which is the most effective? And I think your answer was transdermal, right, Mugdha? Or is there, would you say something else?
It depends on what you're using it for. So it depends if you're using it mainly for vasomotor symptoms, and then the transdermal would be ideal because it has minimal risk and you can step up the doses so that you get the maximum benefit out of it. If it's for genitourinary symptoms, the local gels or the local ring will help more. And if it's to prevent bone loss and for like a cardiovascular protection, then maybe a transdermal or an oral medication.
Yeah.
Now the oral medication also, earlier what we are using was called conjugated equine estrogen, and along with that something known as medroxyprogesterone acetate. They were different. These were synthetic estrogen and progesterone. But now the oral formulations that we get are more of the bioidentical hormones, which will help, have a lot less risk than the synthetic hormones. So for that, maybe the oral medication sometimes works better.
Got it. Does menopause lead to a prolapse of the uterus?
Menopause itself will not cause prolapse of the uterus. It's more because of the laxity of the joints, of the ligaments, sorry, which is post-delivery, post-normal vaginal delivery. It can be because of some people do have inherent laxity of these ligaments. But it can sort of, if you do have a prolapse, it can worsen after you get menopause.
A couple of people have asked the question, are there any side effects to HRT?
Yeah, so there can be side effects to HRT. So that's why HRT has to be used with precaution for the minimum amount of time. Side effects can be depending on what modality you're using. If you're using oral estrogen, only estrogen in an intact uterus, there's a risk of endometrial hyperplasia, endometrial cancer. So we use progesterone along with that. If HRT is used after the age of 60, started after the age of 60, then the higher risk of cardiovascular issues is risk of venous thromboembolism, risk of stroke. So HRT has to be used cautiously for the right person. And there are some chances of liver disorders or some other problems which can crop up, but using HRT transdermally or local applications will not cause any problems, most of the cases.
Got it. Are symptoms of surgical menopause and natural menopause the same? Surgical due to either ovarian or breast cancer, then hormonal therapy is not possible, right?
So surgical menopause basically means that your uterus and ovaries have been removed. If the ovaries have not been removed, they will still keep on functioning, but maybe for a lesser duration. So the symptoms are usually, if the ovaries are removed, that the symptoms can be pretty severe, especially the vasomotor symptoms. And in these cases, we do give HRT, can be used, but transdermal and in the lowest doses. If a lady has breast cancer or ovarian cancer, then it's a relative contraindication. And if she's completed her treatment at a later stage, she can be given, but again, it has to be given with a bit of caution and with monitoring. Even if you're BRCA1, BRCA2 positive and you've undergone a oophorectomy, it can be given. But
Right.
again, it has to be local and not systemic.
Anophorectomy is the removal of your
Yes, oophorectomy is removal of the ovary.
ovaries. Um, Post menopause, if there is bleeding, what is it indicative of?
So postmenopausal bleeding has to be evaluated properly. So bleeding 1 year after your final menopause, final menstrual period, you have to evaluate. It can be because of endometrial hyperplasia. That's the lining of the uterus becoming thick, because after menopause, that lining becomes very thin. It could be because of some polyp in the endometrium. There's a risk of cancer of the uterus, ovarian pathologies. So it has to be evaluated properly.
There is an experience that was shared, a call to MIDI Health, which is one of the companies I mentioned
Yeah,
earlier. A year ago, because I was so desperate, I took a 5:30 a.m. virtual appointment. Has been a game changer for me. I had 20 plus symptoms, and many of them were being treated by a different expert. Once I started HRT, I was able to reduce large groups of symptoms and isolate a few that were especially debilitating. In my case, frozen shoulder, joint pain, extreme fatigue, and severe brain fog leading to depression. This last year, my hormones have been adjusted, and while I don't have a uterus since 2021, I need all three hormones: bi-weekly estrogen patches, daily progesterone pill, and daily testosterone cream. It's still work in progress, and my menopause team is still adjusting my hormones, especially for joint pain. But it's already been a life changer, and I feel positive, energetic, and full of purpose again.
that's really nice.
Then there is one. How can I tell if basically the question is brain fog really perimenopausal issue or early dementia?
Well, that I think you'll have to get evaluated. No, it is important, because for Alzheimer's, dementia, you'll have to get yourself evaluated. But brain fog or issues happening in your perimenopausal age group, maybe you could be started on some medication and you could assess yourself. But if you have any symptoms related to dementia, it's better to evaluate with a neurologist.
And is there a way to tell the difference, Mugdha, like uh, that this is a dementia symptom but not a perimenopause symptom? Is there any such thing, or do they show up in the exact same way?
Can I pass this question to
Yeah,
Rashida?
yeah, yeah. I know. This is not a, I mean, we need a neurologist over here to
Yeah,
evaluate it. But I think this is a question that we'll have to get back to you, Vivian, because I think this is not something that we are can answer intelligently at this point.
yeah.
What are the various cancers that we should test for if HRT is not being given in a 60-year-old woman is postmenopausal?
No, I didn't get it actually.
I think it's a little bit of a combination of questions. What are the various cancers one should test for?
Okay.
And the background for this person is it's a 60-year-old woman who's postmenopausal and has not undergone HRT. Does that change what cancers one should test for, or does that not really change?
So I think after the age of 45 to 50, you have to test for breast cancer. That's you have to do your mammographies. You have to do a pap smear. Pap smear after the age of 60 is not really recommended. If you do it pap smear with HPV testing earlier, it's not recommended to do after the age of 60. An ultrasound to rule out uterine, that's endometrial cancer, and ovarian cancer. But these are the things. And if you've not started HRT till the age of 60, the benefit is not much. And you have to find out, I mean, you should have an indication for HRT after the age of 60. So it could be like you have multiple fractures, especially the vertebral or hip, or wrist fractures where you have osteopenia or severe osteoporosis. In those cases, sometimes we do recommend HRT. We can give HRT in addition to the other medications.
Got it. Smita adding irritability and mood swings. So real. Of course, my husband thinks it is independent of menopause. Please bring Rohit onto this call so that he can see it's not you, it's the menopause.
No, it's definitely there.
Gitanjali's question, my question, estrogen drop affects brain, and so is dementia a bleak possibility in the future, especially if there is dementia in the family?
Yeah, there is a possibility, especially we know that if your symptoms are severe, your menopausal symptoms, especially if they're severe, like the vasomotor symptoms, brain fog, then there is a higher chance that you might develop dementia later. There has been some studies which say that.
Yeah.
So again, yeah.
I know you're already getting late for your flight. I don't want to take up too much more time, but just a couple more comments and questions. Mugdha.
Yes, sure.
One is Dr. Ali Zaidi, who is
he's reading.
He's on this community. He said, I would like to share that a misunderstood risk from MHT from the Women's Health Initiative in the US was an increased risk of breast cancer. There were 30 cases of breast cancer in the placebo group and 38 cases in the MHT group. This was blown out of proportion in the press as a 28% increase in relative risk of breast cancer. Absolute increase in risk for less than 1%. This amounts to less than 1 case of breast cancer per 1,000 women who take MHT. In addition, there was no increased death from breast cancer in the study. And just a useful thing to be aware of.
Yes, sir. That study was, there are a lot of fallacies, especially about breast cancer. Also, I think these women were not evaluated before. Most of these women who had this cancer were estrogen-dependent tumors. They were diagnosed early. There was no mortality. So I think there were a lot of fallacies in this study, especially with breast cancer.
And I think one other comment that somebody else made was the intensity of the symptoms may not be a sign of how badly your risk of disease or many of these other things are. So just because you don't see very intense symptoms doesn't mean your risk is not as much.
Correct. So, and also what was not highlighted, that women in the age of 50 to 59 who were in this study had a lesser, had reduction in their vasomotor symptoms, had better bone health, had lesser cardiovascular risk. So this was not highlighted actually. Right. The elder women were the ones who were affected. So that's the reason that we have the indications have to be right. You have to start it at the right time and stop it also at the right time.
Yeah. Then what does one do if a person has hot flashes sometimes even at the age of 65?
That's very unfortunate, but yes, they can remain for a long time. For hot flashes, what you should do is find out the triggering factors. So it can be a diet. It can be a diet with fat-rich food. It can be alcohol. It can be smoking. It can be stress. It can be lack of sleep. So you try to change those triggering factors. At the age of 65, also, if there are no other contraindication, we can give local transdermal HRT. When you are on HRT, you have to remember, if your uterus is intact, then we are going to add progesterone to the estrogen. So you are going to get your periods again. Again, these symptoms, whatever this medication we give, will help you for the duration of treatment. Usually when we stop the HRT, your symptoms may return in almost 60 to 70% cases. And very rarely the vasomotor symptoms are also seen after the age of 65 to 70.
Yeah. There are questions that are constantly coming, but I really, really need to let you go because you need to catch your flight. Mugdha, if you don't mind, we'll send you the few unanswered questions so that you can give us your listing and post them. But thank you so much, Mugdha. And I really think that everyone learned a lot, and I think you'll see the love that is going to start flowing your way on the screen from all the people who have benefited from it. But I think we need more such conversations because this is like I said, a highly underserved topic, and I think we need people like you who have yourself gone through the learnings and the
Going through.
experiences. So,
I might just add about the brain fog that today I have forgotten to get my passport. Fortunately, I've come early to the airport and someone is getting it for me. So I'm like, lucky. So, yeah, the brain fog can be crazy.
yeah.
So,
And I think that story encapsulates everything, right? This is going to happen. And
I think in India,
yeah.
in India, we need to have more of awareness because it's not there. In the community, amongst doctors, in our profession, I don't think I'm a postgraduate teacher, but we don't teach our students about, it's really not discussed much also. It's just an exam question, but that's not fair.
Yeah.
So we need to have menopause clinics also. And we should have separate menopause clinics, separate from our OBGY, OPD, our OBGY practice, where it's more of a preventive health. And that's not there. And unfortunately, it's still not there in India.
Yeah. And I don't know whether you can see all the comments. Lots of great love for you and for this session, Mugdha. There is a need for a part 2 that we should try and think through and do again if you enjoyed it as much as we did.
I think we should have a neurologist maybe, and the brain fog questions can be answered.
What we should do, Mugdha, next time is we sort of create a panel of 3 doctors of different, and because I think that will provide a pretty interesting conversation.
Yeah.
Right?
I think yes, because a menopause clinic, we've tried establishing one at KEM, and I think it should include a physician or should have maybe a physiotherapist and a counselor and a gynecologist. It cannot be just one person because it encompasses everything.
Yeah, no, that's a great suggestion. Maybe we'll do exactly that. We'll put together a panel and it'll be a great conversation. But again, thank you so much, and I hope you get your flight and your passport.
Yeah, I hope so. Thank you.
All right, thanks. Bye-bye.
Okay,
Thanks, everybody.
bye. Thank you.